Asma, congratulations. It looks great.
Thank you, Mine.
Great job.
Okay,
Great
so
job.
for this case, we have a 30-year-old male who has had painless jaundice, presented with painless jaundice about a year ago. His ERCP showed hilar obstruction with successful cannulation of the only the right ducts. CT showed bilateral hilar obstruction. Hilar stricture was extending into the right to main and right interior and posterior and left main duct. The plan for today is to do spyglass cholangioscopy and spy bite biopsies.
Okay.
We're live.
Professor Hany Shehab, we are live to you. Over to you.
Hello everyone. Hello, Dr. Pradeep, Dr. Main. Pleasure being here. I'm Dr. Hany Shehab, presenting from Cairo. With me today is my colleague and dear friend, Dr. Shehab. He's our interventional radiologist, who is so far doing a great job helping me in this case. So, Dr. Shehab. Okay. So in this case, this patient, he did an ERCP that failed to cannulate bilaterally, because as you can see, it's a complex hilar stricture. It's a bismus 3 or 4. I think we've settled already here in our center a few years ago that these strictures are usually better handled by a radiologist. So he had an ERCP done at another center, and then he was referred to Dr. Shady, who did the PTD. He put drains in the right anterior, posterior, and the left duct. They were large drains. The patient was well. They were 8.5 French drains. But what we need to do is we need to get a definitive pathology. The patient is young. It could be benign. So what Dr. Shady did right now is that he pulled the drains outwards to allow the passage of my spyglass. As you can see, I hope you can see the endoscopic view. Yes, I think you can see it now. The papilla is patulous. Obviously, in the last ERCP, it was a very wide sphincterotomy and then followed by insertion of 3 drains. So now very, very wide papilla. So this helped me insert the spyglass without the need of putting it over a guide wire. But Dr. Shady is keeping the 3 guide wires in place because we intend on putting stents after finishing the biopsy procedure. So if we can shift now to the spyglass view, please. First, can you have a view at the fluoroscopy? If you can have it with us at the same time instead of myself, it would be better. So now we're, as you can see, we have 3 wires coming out. We're at the level of the picture. So we're at the lower end of the common hepatic duct. Now, of course, we will take biopsies, but biopsies, the sensitivity of the biopsies is not really perfect so far in cholangioscopy. It reaches about 74% in the last systematic review or meta-analyses. So we should also try to get an endoscopic impression as much as we can. See? So there were many criteria that were described to suggest that the region is benign or malignant, depending on the view on cholangioscopy. I think the most evident ones are the presence of ulceration, or the presence of periprojections, or the presence of abnormal vascular pattern. We can see here so far that there are abnormal vessels. Okay, so you should not be able to see these tortuous vessels around the stricture. Now we're trying to move inside the stricture. I'm helped here by my great assistant, Mrs. Salma. She's an expert now, and I think she can almost do the spyglass own if we just let her. Rasil. Of course, the presence of the wires makes it a little bit just more difficult to maneuver, but we really need them inside because this patient has to be stented after we finish. So I think right now we're moving into the left main duct. No, I think this is the
proceed. Right.
Ghasil. But what I'm seeing so far is not nice. You see these papillary projections. There is abnormal vascularity. So these are all signs suggestive of a malignancy in this patient. Okay. We hope that the biopsy will be concurrent.
Hany, can you hear us?
Yep.
So here, one of the issue is that the patient had stents across the stricture, right?
Yes, I'm sorry, but the voice is very low. Can somebody please manage the volume at our room? Yes, go ahead again.
So the patient had stents
yeah.
through the stricture before you pulled them back, right?
Yeah. He had the drains, the PTD drains.
Yeah. So so of course, a lot of the changes you see might be related to stents, including ulceration, right? So especially when you have multiple stents go through. So this is why interpretation SPY images are more difficult once you have multiple stents in. You know, and if you look at the literature, the abnormal vessels that you talked about, and you showed us a couple of nice tortuous vessels, and masses are the most predictive of malignancy. Ulcer much less, because you know, like patients with PSC, we see ulceration all the time, but the mass and abnormal tortuous vessels.
Yeah. Yeah, the interpretation is actually difficult on its own without the stents inside. Of course, the stents, yeah, they make things even more difficult. And even, as you said, the inter-observer agreement is pretty low so far. There have been criteria developed. I think the last paper was by Dr. Kahale and his team. They assessed the Monaco criteria and the CRM criteria, but they still show pretty low inter-observer agreement on it. But as you can see here, I think the finding of the papillary projection is something that it's hard to be triggered by the stent. You can see this fibrinous reaction caused by the stents. The ulceration, yes, of course, but the papillary projections, I think, are more in line with a malignancy in this patient, probably.
So these vessels that you see here, this is probably where you want a biopsy.
Yeah.
Yeah.
Biopsy.
So, Moin, do you think this is an area where AI can make an impact in the future?
Yeah, you know, this is, so we've been working on this for a couple of years now, Pradeep. The issue is we've encountered few problems. The quantity of images you can get is not as much as you've done with colonoscopy, you can imagine. The quality is not as good. And also there has been a change in the technology. You know, for AI, you have to be consistent. Yeah. But we've managed now to collect data on about 700, 800 patients. The goal is to get to 1,000. That will give us more than 5,000, 6,000 images. Okay. And we're almost there, but we're hoping that it will be helpful, Pradeep. So that will be the first major study on this.
Excellent.
So,
Hany, how many biopsies do you do? Can you tell us your protocol?
Look, my protocol, to be honest, it's usually I take as much as I can. There is no standard number. If you take it from the literature, it seems that the magic number is 3. Okay, so there are studies that show that more than 2 is better. A recent study, I think, from Florida showed that 3 is not different than 4. But I usually believe that I usually take more because, look, I feel like we're inside. It's an expensive procedure. The patient probably won't do it again. I usually go with at least 5 to 6 biopsies. This is not based on a literature, but I feel it's just a reasonable number. What do you think?
Yeah, so that, I mean, I agree with everything you said, Hany. For the audience, there was actually a randomized trial from Shyam Varadarajul's group published in Clinical Gastroenterology and Hepatology, where they looked at the number of biopsies. There was no significant gain after 3 biopsies. But the way I think about it, 3 biopsies with that you looked at. So you have to verify. Basically, you get the SPY bite. You do a targeted biopsy. And when you bring the forceps out, you have to look at the specimen yourself, make sure it's you got something. So 3 verified biopsies, I think, is good enough. But you can do more. It's not going to hurt, I guess. But I will do one bite per pass. There's no point of doing more than 1 bite.
I think an important point to discuss also with you and to let the audience know about this dilemma is when you have a stricture like this, I mean, a bismuth 3 or 4, do you guys go with an ERCP or do you start with a PTD? If you don't mind, I would like to listen to the opinion of Dr. Shadi here. I think he has a very strong opinion from a radiological point of view. Dr. Shadi, what do you think when you find a higher stricture? Do you think the patient should do an ERCP first or go straight to you?
No, in my opinion, you should go straight directly to PTD.
And why is that?
We can definitely control where we target in the liver. We target a dominant radical, draining the largest volume of the liver possible. And by combined ultrasound and fluoroscopy, I think it's a very simple procedure. Considering that you by ERCP, it's much tougher to choose the radical. Which will you go into?
Okay, so what do you think, Dr. Moin, Pradeep?
Yeah, you know, so there is, I mean, if you can say what's the scientific opinion, what does the literature say, and then what do we say, right? So we tried actually to do a randomized trial. One of my colleagues from Medical University of South Carolina tried to start a randomized trial and had to stop because very poor recruit. But scientifically, we don't have adequate evidence that one is superior to the others across the board. But I think also it's easier for radiologists to manage strictures once the strictures are higher up in the liver. The higher they are, the easier it is for them and harder for us. And the lower the strictures are, the easier for us, better for the patient. So we still do some, and our radiologists do a bunch. But you know, I'll also agree with your colleague. You know, the issue is you want to factor other stuff. The number of procedures, repeated procedures that are done by IR is tremendous. These patients keep coming back. These days, we can place multiple hilar metal stents. You know, and patients come back on a PRN basis rather than a scheduled basis. So I think that's a good option. But I think you know, it depends on local expertise, how good GI is, how good IR is, and patient preference to have 3 drains coming out of their liver, or they want to have internal stents. So I think that factors in as well.
Amen. So what is your impression of this stricture so far?
Yeah, that's you know, that's pretty complex, and of course you're limited by all the wires that are through. There's not enough space for you to see, and the wires also are problematic. You know, I haven't seen the MRCP or the radiographic or the cholangiogram, but I take your word for it that it's a likely bismuth 4. And this is very, very complex to be managed by endoscopy, of course.
Yeah.
I think Hany تعديت الstructure.
Screen. So you can see now, according to the radiographic image, we're going into the right posterior branch. It gets a bit tighter, but it's passable. Screen. Yeah, so now we're passing, so we're deep into the right lobe. I hope you can see the radiographic image.
Yes.
So now you observe the huge difference in the lining of the bile ducts. Okay, so this appears normal. Now the important also benefit of the cholangioscopy is the possibility to map for the surgeons if they're going to do a surgery. There has been a recent publication, I think, from China, where they compared just mapping with the image that you get with the endoscope versus taking biopsies from the apparently normal ducts. They didn't show any quite benefit from adding the biopsies. I'm not sure if this is true if you do it on a larger number of patients. But in my practice, what I do is I usually measure the length of the stricture and just give the description together with the MRCP and ERCP image to the surgeon to them assess the depth of invasion. So now we're going back into the stricture screen. This is we're now into the right posterior, the main right posterior duct. So it is important for the surgeons to know that it is not extending to these secondary branches. It is really very important to them to know that they can actually connect the right anterior duct to another duct, or if they're going to do a hepatojejunostomy.
So, Dr. Shehab and Moeen, can I ask a very quick, maybe a theoretical question, that we've gone past a potentially malignant stricture which we have biopsied, and then you enter the normal looking mucosa. Do you guys worry like how we worry in colon about seeding and truncating the tumor cells, especially because in this procedure you use so much of saline or water infusion, or is that just a theoretical concern?
Yeah, theoretical concern, but it's a concern we talk about. And that's why if you, what we do is go through the stricture, map proximally, and then come back and start manipulating the stricture.
Okay.
So biopsy at the end. We saw recent gastroenterology paper about basically transmission or metastasis of cancer through through the biopsy channel, right?
Yes. Yes.
Yeah.
Okay, so I'll just take another biopsy at the edge of what I believe is the stricture.
And Hany, what you mentioned about staging the tumor and helping your surgeon plan, this data is invaluable. And what I do actually, I take a video and show it to our surgeons. It's really very helpful.
They love seeing this image of these clear ducts. It's very reassuring. It is important here for them.
Yeah, and this is what we're talking about, Pradeep and Hany. You know, so theoretically, for the mapping, we like to mapping normal tissue before we biopsy the tumor itself.
So what I'm going to do now also is I'm going to inject some contrast here to make sure that we're actually talking about the first ducts being from the right anterior system, because it's really very easy to get lost when you're doing the spyglass. So someone's going to inject some contrast now just to make sure where we are.
Screen.
So, yalla. Yes, so Dr. Shadi, I think you're the best one, or at least better than me in interpreting this. So do you believe that now we're in the right anterior, the main right anterior? So
yes.
This is not a second bifurcation after, right?
Segment 5 and 8.
So so this is right anterior going to segment 5 and 8, yes. Right? So if the surgeon would like to make an anastomosis using the right anterior, it's going to be okay.
Hopefully, yes.
Okay, yeah. So this is the image that the surgeon would love to see, and I think this will give the hope for a patient, if the biopsy is fine, to do a hepatojejunostomy. I think so. So any further questions? What we're gonna do, of course, after you, is we're gonna, I think, just take a few more biopsies from the left side, and then over these guide wires, I'm gonna put 4 now, 3 plastic stents, pending the results of the biopsy, and then have a talk with the surgeons. So any questions? Screen.
No.
Hany, are you gonna try to go to the left side as well?
Yeah. This is what I was just saying. I'm gonna go to the left side. Try to also mainly for the mapping rather than the biopsy taking, but mainly it's for the mapping of this stricture to aid the surgeons in their decision. So I think it could be somewhere here. Screen. انزل تحت بالسكرين.
روح ناحية دكتور هاني. لا.
عليا.
ناحية هاني. كمان.
Yeah, so we're still up. So.
Excellent. Dr. Hany, basically to summarize now, you're going to take few more biopsies, check the left side, and then you will put a stent in.
Exactly.
Excellent.
3 plastic stents for now. And the question was, is you put a metal or a plastic? I think.
So it depends on the surgical resectability, right? So if this patient is not going to be a surgical candidate, you can eventually change these to a metal stent. But right now, you're still determining resectability with staging, right?
Exactly. So this is why I think I'll probably shift to the option of the plastic stents.
Yes.
Yeah.
So metal only when the patient is deemed unresectable.
Yeah.
Because as everybody knows, the metal stents are uncovered, so they're not removable. So you can change a resectable patient to an unresectable patient.
Mm-hmm.
So, Dr. Hany, this has been an excellent demonstration, beautiful images, very nice imaging,
very nice
discussion. Really impressive. Well done. We've run out of time, but you've demonstrated everything we asked you for. So well done for keeping it within the time. We're now going to move on and from